Hello and welcome to Duncan Toplis On Air. I'm Caroline Cleary. I'm Chief Marketing Officer at Duncan Toplis, and I'm joined today by Kay Botley, who is our Head of Healthcare and Director. We are going to be discussing GP finances and healthcare practices today. Welcome, Kay.
Hi, Caroline.
So I suppose the first thing for our listeners is to explore what is your role as Head of Healthcare? What do you do on a day-to-day basis?
I would say that my role as Head of Healthcare is really making sure that we've got the very best team with up-to-date specialist knowledge for the healthcare sector so that we can provide the very best service to our lovely healthcare clients. The world of NHS is ever changing. No 2 years are the same. There's always changes. So we need to make sure that we're up to date with those changes. We also like to think outside of the box and not just provide finance support, but also look at what else is happening in that sector. And we build a lot of good relationships with other professionals. So, for example, solicitors, surveyors, NHS pension specialists, and we build on those relationships to make sure that we keep up to date with what else is going on in the sector so that we really can support our clients as best we can, and build those relationships and flag to our clients if there's anything else going on that they really should be aware of, anything that's specifically going on in their practice that we need to flag to them with the GP practices. And so it's really like one big family, I think, the clients and the team. I've been working in healthcare for 28 years now, and a lot of the team that are specialists dedicated 100% time on healthcare have been with Duncan Toplis for many years as well, many of them in excess of 20 years. So we've really built some great relationships with our clients. We're working with some that I've been working with for 28 years now, which is really nice. And my role is just to make sure we continue to give great service to those clients and have a great, happy team.
So I've known you for 6.5 of those 28 years. And I think the thing that has always come across is how much you enjoy working with GPs and their practices, how much you love it. What is it about the sector that really gives you that drive to do as well as you have done?
I do. I absolutely love it. Like I say, we've got some great clients, great GPs, great practice managers that we build the relationships with. I think I've just got such an interest in the sector, various things through my life's history involving me with healthcare professionals. A real drive to see them succeed and to help and support in what way I can and the team can. So there is a real passion there. One of our team members, we joined us from practice, and she had picked up on the passion that myself and my colleague that were working on that job had, and said, I want some of that. And she's joined us. She's amazing. And she said, I wondered whether it would really be like that when I got here, but it really is, isn't it? So
that's really brilliant to hear, isn't it? And I suppose now we're digging into your expertise a little bit, and we're now Q1 of the new financial year. What has the recent budget from the UK government meant in terms of general practice? What challenges do you think they face? What advantages do they have from some of the changes?
Yeah, so there's a few advantages that came out of the budget for partners in GP practices. For example, Class 2 national insurance was abolished from the 6th of April. Class 4 national insurance had another 2% shaved off it. 1% had been dropped in the autumn budget. So now instead of 9%, they're paying at 6% between around 12.5 and just over 50,000. So in total, those changes save a GP or a partner earning more than 50,000 a year, around £1,300, just over £1,300 a year. And that will be felt in the January 2026 tax bill. The high income child benefit charge, that has altered as well, so that may benefit some of the GPs, but unfortunately all the benefits that they're going to see on the tax savings side will certainly be counteracted, unfortunately, by the terrible contract that they have been presented with for the 24-25 year.
So what does the new contract look like for general practice?
It really doesn't look good as it stands at the moment. So over the years, the increase that the practices have seen on the GMS contract has not met the increases we've seen in inflation and rises to the national living wages. And obviously staffing is the largest cost for GP practice, aside from dispensing practices with their dispensing costs. So it really hasn't been good news. The BMA are in dispute with NHS England now over the contract. There was a referendum vote and 99% of around 20,000 GPs and GP registrars did reject the contract. So now they're moving to a non-statutory ballot on collective action, and that's opening in the middle of June and ends at the end of July. And that is really to say they want to send a clear message to government that the GPs are ready to stand up for a better service for patients and to protect practices, because there's a real concern that because the contract uplift hasn't given them what they need to be able to provide staff with the pay rise that they deserve, as well as the contractors, the partners themselves, then they really can't deliver safe care really within the contract sums that they're getting. So they're really having to think outside of the box and look as they progress into this year as to how they can make their practices survive.
And if I recall correctly, in the previous contract, the media were reporting a 6% uplift for practices, which I understand caused a few challenges.
It did, yeah. So they were reporting a 6% uplift to cover staff pay increases. What they didn't say was the core contract sum for a practice is just over £100 per weighted patient. So the weighting applied to a practice is looking at various factors, so the demographics of the patients and deprivation and so on. So of that core contract sum that the practices are given, there's only a proportion, which is around 44% of it, that relates to staffing costs. So the 6% uplift that the practices were given was 6% of a proportion of the contract sum that was then based on a weighted patient list size. It was absolutely nothing to do with 6% looking at the staffing costs. So a lot of practices are funding a number of salaried GPs as well as their admin, their reception, their other clinical team. And they were being faced with trying to explain to their team that they weren't receiving 6% to pass on to them. It wasn't a 6% on their gross pay. They were receiving this 6% on a proportion of their contract sum, but that also had to take into account that the practice had to fund the on costs, so that the employer's national insurance and the employer's pension contributions. So it was really difficult because the practices really want to pay their good staff members and to retain them. They don't want to lose them. So practices were faced with different issues and at different levels of issue. Some it wasn't such a big issue, and some it really was a huge issue, depending on what their staffing costs look like and how big the practice is. So it was a really difficult time, and we were certainly recommending that our clients sat down with the team and explained to them, because there was that lack of understanding. You see it in the press, 6% uplift for NHS staff, but actually when you get down to the bare bones of it, it just isn't, and it causes the practices such an issue to then have to explain. And the practices were passing on everything they possibly could to their staff, because of course they want to recompense them fairly, but they also had to be mindful of the other costs that they were incurring. And although a lot did end up out of pocket because they weren't just giving what they were given, they were giving more than that, because they were having to, then it really did have an impact on the bottom line. And ultimately, the bottom line is meaning that the partners in GP practices are taking a pay cut. So over the years, with that national living wage increase, with the erosion of the GP contract sum effectively because of the inflation rates, then it is the partners that are suffering.
And that's going to be a real challenge. So if you were able to reach out to practices and the GP partners, what would you suggest they need to be doing right now?
Well, one thing that they really need to make sure they're doing is within the practice that the finance managers are looking at preparing cash flow forecasts and budgets. Absolutely essential, because they need to know what impact the contract changes and the rises that they are having to give to their team are going to have on the ultimate budgets that they've got. And that's going to allow them time, if they do that on a rolling basis, to react to any point in time where they think they're going to struggle with cash flow and budgeting. They need to be reviewing various things within the practice to see how they can mitigate the impact of this contract. So they need to be considering, are their team doing any work that isn't bringing in any income? If they are, can they replace that work with some income that does attract funding for the practice? They need to be educating the team. The team need to be aware of their impact on the finances. So, for example, clinical people will be coding when the services are provided, for example. So they need to make sure that the clinical team are aware of the impact that their actions are having on the finances, because if it isn't coded correctly, the data isn't collected correctly, the claims aren't going in and the money isn't flowing through. So they need to be aware of the impact that they're having on the funding. They also need to be looking at different areas. So, for example, the private fees that they charge, are they charging a correct amount for those private fees? Do those fees need reviewing? Are they educating the patient? So, for example, flu campaigns is a prime example where practices have over the last year sometimes seen losses being made on providing the flu service. And challenges around that are, if they're buying the flus late, they're going to cost more. So make sure you're buying your flus early. Also plan the flu campaign. Make sure the patients are aware of the impact that they have on the practice. If they're not going to the practice and they're probably going to a pharmacy, the practice is losing out on that money. They've probably bought in flu stock, hoping that, a considerable proportion of their practice population will come and have their flus with them, and then they're probably getting wasted. They're not getting the fees in for actually jabbing the patients and the refunds for those flu drugs. So it can have quite an impact, as can other services. So it's educating the team and educating the patients really to help support them. It's also looking at how they can work collaboratively. So we've got primary care networks and federations around some of the practices. So the practices need to be talking to them, making sure that they're aware of what income streams are coming in and how they can benefit from those income streams. So looking at additional roles reimbursement scheme, how can they benefit from support with staffing costs, either by reimbursements for staff that they're using in-house, or perhaps tapping into staff that are employed by the PCNs that they can bring in to use and help with workflow and help with staffing within the practice.
And so you mentioned the PCNs, the primary care network, and I understand more and more funding is going into those primary care networks. You've mentioned some areas there that practices can get involved in. Is there more that they can do for their parts in engaging with the PCN?
Yeah, so they really need to be absolutely engaging with a PCN. Not all practices seem to, most do, but occasionally you come across practices that seem quite distant from the PCNs. They're not really working with them or aware of what's going on with them. So it is being on the ball, knowing what is happening in those PCNs, what income is available. And also occasionally we've seen practices start to provide a service, which is great, but it's a year ahead of when the funding's available. So they've run it for a year without any payment, which obviously has a knock-on impact on their finances. So they need to be aware of when services are starting, when they can start to deliver, and what happens in the meantime. So it's really thinking about how they tap into that and when, to make sure that it benefits their finances.
So some key challenges in the space, but also some great opportunities for practices to work more collaboratively and with a greater awareness of their finances too. Are there any other hot topics in the area at the moment that you think's worth highlighting?
Yes, so we've seen a few hot topics recently. One is seniority. So seniority was a payment that was given to GPs, and it was based on the number of years service within a GP partnership. And this was stopped. The payment was based on the number of years that they'd worked and what level of income they had. And all of a sudden, out of the woodwork, have crawled some clawbacks. So we've had some clients who have been asked to pay back some of the seniority money. And we have recommended that they raise a dispute with PCSE to stop them automatically taking those amounts in June, because what they hadn't at that point in time provided was a breakdown of how that had been calculated. And certainly with a couple that we looked at initially, we found the figures were wrong. So for example, there was a GP who had earned above the threshold for qualifying for the seniority payment, wasn't in the pension scheme, had submitted a pension certificate for seniority purposes. PCSE hadn't processed it properly on the system, and so now they've come back and asked for £6,000 to be paid back to them because he wasn't eligible for that payment, which was totally incorrect. So it's just allowing time for the practices to either check themselves or ask their accountant to check, is this money really due back or not? So that's one of the hot topics. Another one is that the long-awaited NHS premises directions 2024 have come out. So the last ones were 2013, and that's all around NHS properties and GP practice properties that want to extend or build, and what funding is available to them, and the payments around that. So if anybody is looking at extending or building, then they really want to be looking at the new premises directions, because they are more favourable than the previous ones for practices looking at that.
And so some real highlights there of what's happening in the sector. And then I suppose with that will come requests for recommendations. What are those key recommendations for practices right now?
So the key recommendations are to really take stock of where you are with your finances as we head into 24-25. As you say, we're well into Q1 now. We've mentioned obviously some of the key areas to look at. Another hot topic, I would say, really within practices, and one that we talk to our practices about, is around the dispensing function, whether you're dispensing or not. So for the non-dispensing practices where they're actually giving injections, for example, to their patients when they're going in, it's making sure that within your practice you are aware of what you can claim and what you can't claim. So for example, sutures, some of them are reclaimable and some of them aren't. So practices need to be aware of what is claimable, what isn't claimable, and using what is where possible. They need to make sure that their staff are aware of what can be claimed, how much is being claimed, and what they're buying in at, to make sure that they're being profitable, because that can soon have a knock-on impact, and we've seen in practices sometimes losses being made on that. So it's really important now more than ever. A review of your costs. Now that is not slashing costs, finding the cheapest, because as we've seen with all sorts of expenditure in practice accounts, that's not the best method. That can have an equally detrimental knock-on effect. Really just looking at value for money. And staffing costs is the biggest cost that practices have. Obviously, we've talked about having the new national minimum wage, national living wages increases. So it's thinking around sickness policies, holiday policies, planning for holidays. If you plan well in advance, you're more likely to get cover within the practice or at a lower cost than leaving it all to last minute and then having to probably pay extortionate locum fees to get last minute cover. So it's really planning ahead, doing those cash flow forecasts, doing those budgets, thinking about what is happening through the year, and being aware of those claims and those costs is really important.
And you've talked really well there about the practical elements of what practices can do. And here at Duncan Toplis, we have a lot of brilliant accountants, but I wondered if it's worth explaining to the listeners, touching on what you have done before really, is what is the difference between having an accountant and having a specialist accountant for your sector?
I think the easiest way to answer that question is possibly by giving a few examples of what we've seen when people haven't had specialist accountants. The key issue is people who aren't specialists don't usually understand NHS pensions. So when we've picked up work from a non-specialist, we've often found big problems with the NHS pensions that's either caused practices cash flow problems or GP partners or other partners in the practice pension issues that they may not even ever have realised that they had they not changed. So it is really important. We've picked up practices where the accountants haven't provided for balancing payments of pension. So each year a GP partner or a partner in the practice has to prepare a pension certificate. and they'll have had pension contributions taken throughout the year as an estimate on account of what they think their pension liability will be. We then prepare the certificates, and the balance is either paid or refunded, depending. And what we've seen, I'll give one example of a practice we took on. There were 3 years worth of balances taken all of a sudden, and the practice were not aware that those balances were going to be taken. They hadn't been accounted for within the account. So suddenly the practice had a cash flow issue, and the 2 GPs that were impacted were suddenly being asked to put in a lot of money for their pension liabilities that they weren't expecting to. So that is obviously not helpful for the practice or for those individuals. We've seen accounts with goodwill in, which just isn't allowed in the NHS. Also, we have seen other issues. So VAT, for example, if they're not specialists in NHS GP practices, they often don't know about the quirks of VAT. And so we've gone in, and on 3 practices that I can think of immediately, we've found over £25,000 worth of VAT back claims that we've found for practices because the previous accountants just haven't known the quirks of NHS and VAT.
Wow. Well, and what fantastic work that you've done for your clients in those examples too. Thank you, Kay, for joining us today. It's been really fascinating learning more about the sector, but also how much you enjoy it. Hopefully you'll be back soon.
Thank you very much. Thank you.